things are going to start closing down again. So this is a beautiful, pretty picture of the coronavirus. I'll show this to show you the spike protein. It's actually a trimer here. And as you all know, that we're looking to, for the most part with the vaccines, we have now block the spike proteins. This is the virus, this is the spike protein. This is the receptor known as the ACE2 receptor. And you might know the term ACE2 because we have ACE2 inhibitors as long-standing effective antihypertensive. So this is the virus. These are the spike proteins. This is just a little piece of very recent historical information. Husband and wife, Dr. Tarucci is born in Turkey. Dr. Sayan, I believe, was born in Cyprus, the daughter of Turks, co-founders of BioNTech. This is a favorite quote I have. If it were up to critics of capitalism and globalization, he added, there would be no cooperation with Pfizer, but that makes us strong. An immigration country, market economy, and open society. And you might be surprised and not altogether cheered for the fact that they're talking about Germany today and not the United States. But they literally, as about 2 weeks ago, after this was already commercialized, still did not have a written contract with Pfizer. So you're all familiar with this. And it does have some relevance when we talk about the different kinds of vaccines. So you know that DNA is transcribed into RNA, and the vaccines we have now have so far have nothing to do with DNA, which is relevant in terms of the safety concerns, not necessarily safety realities, but safety concerns. RNA happens to be a very fragile molecule. As you probably know, it is packaged into a small RNA inside a lipid nanoparticle. I describe it to patients. Imagine this is sort of that glob in your chicken soup. It's stabilized. The RNA in the lipid particle is more stable, and that's how it is delivered to places like Refuel, which have been remarkably successful in having folks vaccinated, as you know, and some of you probably were doing the vaccinating, and I am in awe of people who have been spending their time doing this. So how does this medication get into the cell? How does it get? How does that RNA vaccine get into the cell? This is how. People like the people in Refuah, this is how it gets into the cell. Frida Bernhardt, this was on Refuah, 101 years old. The second day was around when the first to do so part of the federal nursing home vaccination program that began that day. That was December, well, I don't remember the name, but the date, but it was, as you know, several weeks ago. That's how it gets into the cell. So IBD, what's IBD? And as you know, this is not IBS, not irritable bowel syndrome. And sometimes patients say, gee, I have this terrible disease, IBS. They might be very symptomatic, but it is not IBD. IBD is inflammatory bowel disease, which is basically the title of two diseases, Crohn's disease and ulcerative colitis. These are chronic lifelong diseases. So if you get it, as most people in your teens, 20s, and 30s, unfortunately, this is a lifelong disease. Most common demographic, eightfold compared to non-Ashkenazi Jews, are the Ashkenazi Jews, and almost certainly even a greater prevalence in the Hasidic Jews across all of the Hasidic groups, in large part because the genes, the genetic pool that increases the risk of Crohn's disease and ulcerative colitis is sort of, you think of it, hyper-concentrated within what was essentially small communities going back to the 1700s. And these are now a genetic pool that is very concentrated. And it's not uncommon that you'll see many siblings, many aunts, uncles, multi-genic families with Crohn's and colitis. So something certainly you're seeing in Refuah. So Crohn's disease, what are the clinical features? There's not a lecture about inflammatory bowel disease, but just to put it into context, your patients can have it with Crohn's disease, involve anywhere from what we say the mouth to the anus, but far more common is the involvement of the terminal ileum, the last piece of the small intestine, and the large intestine, the colon. Presentations might be what we call inflammatory, where they might have inflammation in the small bowel or in the large intestine, which results in typical pain, diarrhea, bloody stools. With time, in about half of those patients, inflammation becomes stenotic, gets scarred down. Once it gets scarred down, patients have obstructive symptoms because food is not getting through there. To the extent that patients has inflammatory component, they might very well respond to our medications, largely immunosuppressive drugs, because this is a disease that is mediated by a hyperimmune system. And we'll get to that in a moment. But once you've already had scarring, this what we call fibrosis, narrowing, no medication is going to help that. And that patient's ultimately going to need surgery. I say historically, about 70% of patients, because with our new medications and our new anti-TNFs, quote unquote, are not so new. People forget Remicade, the first anti-TNF, has been around since 1998. So we're talking about 22 years. So these are not new meds. And this is part of the conversation I have with patients when they think they're being put on a new medication when I talk about Remicade or a different anti-TNF drug. Ulcerative colitis, on the other hand, is limited to the colon. If it's small bowel disease and it's not ulcerative colitis, it's Crohn's. Symptoms are always of bloody diarrhea. If they've had diarrhea for many years, it's never been bloody, and it's unlikely to be ulcerative colitis. And about 15% of our patients with ulcerative colitis require surgery. But in this case, it involves removal of the entire colon. Crohn's disease, they have a resection generally of a section, a limited resection. In ulcerative colitis, it involves the entire colon coming out, 10 or 15% of patients. Again, teens, 20s, and 30s. This is a real, for many people, devastating life event. But in fact, the patients who have been very sick and they get this very sick colon out are inevitably very grateful that they did have the surgery. So let's talk about the medications, because this will impact on questions about who should get vaccinated, when you should get vaccinated. So the drug that's sort of first line, certainly for ulcerative colitis, often used for Crohn's disease, although it's not really effective for Crohn's, but traditionally has been used as well. These are the 5-ASA, 5-aminosalicylic acid drugs, also known as the mesalamine drugs. You might know them as, and now they're all generic basically, but Azacol, Aprizo, Lialda, Valsalazide, Polizal, Pentasa. I'm not sure if I left any out, but these are all essentially interchangeable so long as you make the appropriate dose adjustment. And the oldest of these is sulfasalazine, a sulfidine, which we rarely use because if we want to dose escalate, many patients don't tolerate the sulfa component. So for many years, we're using one of these 5-ASA drugs, which is not an immunosuppressive drug in the sense that we think about the drugs that we do use for moderate to severe disease, which are the steroids. Oral, we typically use prednisone. In the hospital, they might get IV steroids, IV hydrocortisone. These are the bad actors, and there should be no patient. And if you have a patient who you're seeing and you see they've been on prednisone for more than blank number of months, you could fill in the blank, 3 months, 4 months, then that patient is not being adequately treated. Either the prednisone is either they become dependent, and in that case, the risks of adverse event far outweighs the benefit, and that patient is either prednisone dependent or prednisone refractory, must get off that medication and on one of these alternative meds. I have, in a practice of thousands of IBD patients, I don't think I have a single patient who's on more than 5 milligrams of prednisone, and even less than 5 milligrams, almost none, but very rarely, and it should be a rare event that you have a patient who says, well, on 3 milligrams of prednisone, I do great. When I go less than 3 or less than 5, I run into trouble, but that's rare. Usually if they need prednisone, they need it in bigger doses. 6-MP or 6-mercaptopurine and azathioprine have been around for about 60 years. We largely think of them as, quote, steroid-sparing drugs, not that effective in treating the acute inflammation, and certainly not quickly. They take 2 or 3 months to work, but certainly effective. But again, they are old medications, and in fact, these other medications that we're about to get to are, in fact, clearly more effective and safer. Patients think of our biologics as, quote, causing cancer, and chiefly that means lymphoma. The drug that has the greatest risk of lymphoma is either 6-MP or azathioprine. Methotrexate, another ancient drug, also used very infrequently as a steroid-sparing drug in Crohn's, not ulcerative colitis, barely had any traction in this country, used more originally in Canada. And the anti-TNF drugs, again, Remicade being the first one, shortly after that, Humira, Simponi, which is very infrequently used compared to Remicade or Humira. It's the third anti-TNF specifically for ulcerative colitis. and a drug that's almost never used because it was the third to market and not as effective as Remicade, Humira, Cimzia for Crohn's disease. We have a medication called Stelara. Even if you don't have a single patient with Crohn's or colitis, you might know this drug because it's been around for 10 years for psoriasis, and then psoriatic arthritis. About 5 years ago, approved for Crohn's, about a year and a half ago for ulcerative colitis. It blocks IL-12, interleukin 12, and interleukin 23. And I'll get back to that in a moment, why that's important to know that specific inflammatory mediator, also known as a cytokine, what cytokine it blocks. Entyvio, and obviously anti-TNF drugs, what it's blocking is TNF, tumor necrosis factor. Entyvio blocks T cells, inflammatory T cells, from specifically binding to their receptors just in the small and large intestine. It's approved therefore for Crohn's and ulcerative colitis. The beauty of Entyvio is that it only blocks inflammatory cells headed to the gut, so you don't get systemic complications. Similarly, Stelara is a remarkably safe drug. No increased risk of infection, no increased risk of lymphoma. Anti-TNFs do have an increased risk of lymphoma. The number I quote is roughly 1 in 5,000. Again, the largest risk of lymphoma, 6-MP or azathioprine. These are all immunosuppressive drugs. Xeljanz, which is a pill, is called a JAK kinase inhibitor, the first one approved. Doesn't work in Crohn's at all, works very nicely actually for ulcerative colitis, and there are going to be other JAK kinase inhibitors coming to the market, almost certainly, probably 2 or 3 within the next few years. One of them has already been approved for rheumatoid arthritis and is now being studied phase 3 in ulcerative colitis and Crohn's disease called Rinvoq, upadacitinib. These are JAK kinase inhibitors. The drug ends in nib. It's a JAK kinase inhibitor. Okay, so how about your patient with IBD? And there are many, many at Refuah. I know a bunch of you folks. It was one of my very happy intervals in my professional career, the years I worked at Refuah. And I still have, as you know, very close relationship with Fanny Sternberg and Jerry Schwartz, who frankly could take care of the IBD patients as well as we can at Mount Sinai. And Jerry is a treasure. Besides being a wonderful primary care doctor, which I'm sure you guys know, he's really a superb gastroenterologist. So IBD and the risk of COVID. Patients with IBD, Crohn's and colitis, are not at increased risk of COVID infection, okay? In March, when we were saying this, based upon a group of international IBD experts from around the country, every Friday, around the world, every Friday morning in March and the beginning of April, we'd have a conference call at 8 a.m. Because it sort of didn't interfere with anybody's sleep pattern. In China, they were about 8 p.m. In Australia, the same. Israel, Brazil, Italy, Spain, France, England, multiple cities in the United States. We'd have a meeting and we'd put out ultimately guidelines in terms of suggesting how to treat IBD during this era of COVID. And all of it was based on zero data because it was coming out in March. Turned out all these guesses, educated guesses, turned out to be the case. We now have good demographic data when you look at insurance databases across the country of several million people, that if you look at everybody's code for Crohn's and colitis, everybody's ICD-10 for COVID, and then look at everybody without Crohn's and colitis and COVID, the percentages are the same. So given the same precautions, which hopefully they're taking, the risk of COVID is not greater in IBD. Patients with IBD, if they do get COVID, well, we'll come down in a second in terms of severe outcomes. The exception to that no increased risk is unless you're on steroids. That increases the risk. And as you'll see in the next bullet, it increases the risk of bad outcomes. One of our former fellows who's still at Sinai, Ryan Garrow, who's a superstar, he put together what's known as the secure, like a key and a lock, secure COVID IBD database. And it's really become a treasure because there are now over 4,000 patients, and doctors around the world are encouraged to enter their data. And it's publicly available. It's a very useful resource. It's very easy to follow. Several papers have come out of it. And if you go to COVID IBD or secure COVID, it'll come up. And what's clear there, and not surprising and not different than other groups of patients with COVID, is the risk of severe outcomes, defined very simply, because Ryan wanted to make sure that you could not be discouraged about doing some extra homework about putting information in the database. They said, let's design a database, takes 5 minutes or less. So if you wanted to enter a patient, you don't need to be a doctor. My PA, Michelle Kieslis-Hunt, is actually on this committee, the SECURE committee. All you need to say, Crohn's disease or ulcerative colitis, what's your impression without any fancy measurements? Remission, mild, moderate, or severe? What meds were they on? Age, and comorbid conditions. And you don't need to give a long history. You just say COPD, coronary disease, liver disease. No more information than that needed. And outcomes. Very simple. Severe outcome, bad outcome as hospitalization, ICU, ventilation, intubation, and death. Boom. Composite outcome, very simple. You didn't have to put in fevers and weight loss and cytokines. Very simple. And what's been very consistent, the first look was when we had about 200 patients, now 500 patients, now it's over 4,000 patients. What increased the risk of bad outcomes was clearly, not unlike every other population, age greater than 65, two or more comorbidities, and we'll get to comorbidities as it applies to IBD and the vaccine in a moment, and prednisone more than 20 milligrams a day. Now you might say, gee, that doesn't make sense, because we know from the recovery trial, patients who are becoming oxygen dependent, need a ventilator, those patients actually do significantly better on dexamethasone. But it's important to distinguish between prednisone 20 milligrams a day, that at which time you get sick with COVID, in other words, you're coming into your COVID infection immunosuppressed severely, or you're treating the downstream complications of COVID, the so-called cytokine storm, where you're trying to use medication that is an immunosuppressant. What happens, and you're probably all familiar with this, mild COVID or asymptomatic COVID, there's some mild COVID inflammation, typically in the lungs, the upper respiratory tract. The patients that are getting into trouble is when the COVID unleashes this storm of inflammatory mediators, or this cytokine storm, and you can actually measure them. You can measure TNF, you can measure IL-12 and 23. These things are measurable, and we know if you inhibit them, and say with dexamethasone, at that point, the outcome is better. Now, medications, what is the effect of medications on the likelihood of a severe outcome? You say, gee, any IBD patient, I just told you, unless they're on steroids, are not more likely to get COVID, but if they get COVID, they're probably not doing well because they're on an immunosuppressive drug. The answer is that would stand to reason, but what we found, somewhat to our surprise, but now very consistent, and we're up to 4,000 plus patients and a couple of hundred on the anti-TNFs. If you're on an anti-TNF, the odds ratio of getting a severe outcome, remember, hospitalization, ICU, ventilator, or death, was only 69%. The risk was decreased by about 30%. On the other hand, combination therapy, if you're on combination of 6-MP and an anti-TNF, or 6-MP azathioprine by itself, the likelihood of a bad outcome was fourfold. Prednisone, which is not on this table, eightfold. If you're on 20 milligrams of prednisone or more, when you became infected with your COVID, the likelihood you would have a bad outcome was eightfold. So the guidance we have for use of medications for the IBD patients without COVID, and this goes back to March when we sat down Friday morning, 8 a.m., and made recommendations based on no data. It turned out to be right on, fortunately. You continue all the meds except prednisone, which you can't necessarily stop abruptly. You get prednisone withdrawal, steroid withdrawal, but you aim for a rapid taper. Continue any IV infusions, typically Remicade or Entyvio, that are outpatient infusions. We actually, interestingly, said don't start doing home infusions. And why is that? You think patients safer at home. You weigh that safety against the likelihood of the patient who's been coming in, getting regular follow-up on a regular schedule, now hoping that they get as good follow-up as home. Number one, you're not sure what the nurse coming home into the home is in terms of their safety and their current status. And patients who are getting outpatient infusions, we said continue going to either the hospital, the infusion center, your doctor's office. And we had gone in every day. One of my partners, Jim George, Pete Lagnani, myself, were coming in every day. One of us, or two of us, or some days three of us, we try to stay out of the office in case all three would get exposed. And we were doing infusions. Unfortunately, maintaining very strict precautions, we have been very fortunate. And the patients maintain their therapy on schedule and don't fall between the cracks. Avoid all non-emergent endoscopic procedures. We weren't doing routine colonoscopies. We were only doing procedures if they were truly emergent. We were eliminating all CAT scans unless they were truly emergent, trying to keep people at home. You remember those horrible, horrible days. So, okay, so how about, what do you do if your patient develops COVID? What do you do at that point? So we stop all the medications. Prednisone, you have to taper quickly, but that one especially you have to stop. And you'll say, gee, why is that? I just told you that Remicade, Stelara, and Entyvio, it reduces the risk of bad outcomes. Right now that we're 9-10 months later, we might be less hesitant to stop them, in fact, except for prednisone, unless the patient is very sick. Having said that, we generally will hold them. Then when to restart them, that's a bigger question. And we have, quote, a non-testing strategy. We've tried to avoid doing the, quote, testing strategy, whereby you need 2 PCRs within 24 hours being negative before starting the medication again. We saw, and in the CDC back in about May or June said this was a reasonable strategy to tell you that you are no longer infected. The problem is, as you know, patients can carry PCR, positive PCR, just having some RNA debris and still be positive. And the patient might look like they're positive for months and months. Right now, we do a no testing strategy, which means you hold the biologics until the patient's been afebrile for at least 3 days without taking any antipyretics. But obviously, we have to do a risk-benefit analysis. Let's say this is a patient who had a fever of 100 for 2 days and a sniffles, and you held the, say, Humira. Now it's 3 days later, you're ready to take your usual dose, that's fine. Let's say on the other hand, the patient was struggling to avoid intubation, was intubated, and now they're home and they're due for their Humira dose. And on the one hand, they've been very sick with their COVID, and now we're learning, unfortunately, about these long haulers. And maybe they've been stable on Humira for months or years. So you weigh the risk and the benefit. Do you really need that Humira in a patient who's been really sick with their COVID, or could you put it off? And I would say that that is the risk benefit that we put into consideration. Okay, so let's get to IBD patients and vaccinations in general. And in terms of health maintenance, we've been paying a lot more attention to this in the last few years in general before we talk specifically about COVID vaccine. We want all our IBD patients up to date on all vaccines. And the right way to do things is to make sure all our patients, when we first meet them, before they get on one of our many immunosuppressant drugs, is that they are immune to everything. And frankly, most gastroenterologists are not doing this, but we should, when we first meet the patient, check their MMR, because that, as you know, is a live vaccine, and you can't give the patient once they are on the immunosuppressant. So if you have the opportunity, you want to vaccinate them, make sure they're immune as they need to be, MMR, and you will make, that's the live vaccines we're concerned about. We will also want to check for Hep A, Hep B, which have vaccines, and obviously annual influenza vaccine, the injectable, not the inhaled, which you know is live. And also, and this is important because under the age of 65, you're not thinking about this necessarily, they need to have a pneumococcal vaccine, which is not live, and the regimen is Prevnar as the first dose, 8 weeks or more after that, Pneumovax, PPV 23, which has the 23 pneumococcal antigen. So that's what we use. And in reality, what we do pay attention to is that we're about to start an immunosuppressive. We make sure they get their flu, we make sure they get their pneumonia vaccine, and if we can, we get them the shingles vaccine. Now it's not live. If you're using a shingles vaccine, which in particular 6MP, BAC kinase inhibitors are the ones that are most likely to get shingles. The new shingles vaccine, probably about 5 years already, it's not so new, Shingrix is something they should get, okay? Not the old Zostavax that was live, okay? Now, if you're on immunosuppressants, this was a big deal about a year or two ago when we had the measles outbreak. I would have all my patients on anti-TNFs calling me, and they said there's someone in their community who they hear is positive for measles, and they went and they got tested and they don't have antibodies from their residual from their childhood measles vaccine. Where can I get the measles vaccine? I said, you, use a Yiddish expression, you dafka can't get measles vaccine because you are immunosuppressed. And if you get a measles live vaccine, you're at risk of getting the measles. What do? You maintain very strict precautions and in general, make sure everyone around you has been vaccinated and let that be a lesson to the future. So IBD and COVID vaccine guidance. And we are, as gastroenterologists, as IBDologists, getting many calls, emails a day. So like with all other non-live vaccines, our patients, our Crohn's and colitis patients should receive non-live COVID vaccines. And these will include the mRNA vaccines. And you're familiar with the fact that mRNA vaccines are the currently available Pfizer and Moderna. DNA vaccines you're going to be hearing about shortly, and that refers actually to the non-replicating adenovirus vector vaccines. There are others, but these are the ones you're going to be hearing about soon. And that is Johnson & Johnson, and I have no inside information, but I have a hunch they've completed enrolling 30,000 patients. They were going for 60,000. They're seeing enough cases. They probably don't have to go to 60,000. They are using what's called a non-replicating adenovirus. So is AstraZeneca. They are different adenovirus vectors. What are these? An adenovirus is what we see causes the common cold. In AstraZeneca, it is actually an adenovirus that causes the common cold, or is present at least in chimpanzees. And one of the multiple conspiracy theories out there is if you take a COVID vaccine, I swear I've seen this online, you will turn into a monkey, or that you are messing with somebody's DNA, because the adenovirus vaccines contain not RNA but DNA. So those adenoviruses are purely the vehicle, the carrier. They are non-replicating. They've been killed, the adenovirus, and in there they've been engineered to have the DNA for the spike protein. So the adenovirus has nothing to do with launching an immune attack, but is the carrier vehicle to bring DNA into the cell, and the DNA is there to be transcribed and then translated into the spike protein. Just the way mRNA is there to translate into the spike protein. The adenovirus from J&J, from AstraZeneca, the adenovirus is just the carrier. It's not a live vaccine. And that's going to cause some confusion. That's probably going to lead to people saying, I don't want to get a vaccine, that I'm going to get adenovirus infection. And certainly not from a chimpanzee. So IBD meds and COVID vaccines. So the same organization called the IOIBD, International Organization for IBD, had a series of meetings, and the last one was about 3 weeks ago. They've put together their recommendations. It's going to be published publicly shortly, but I could give you, here's the secret. The answer is every drug you're on is not a contraindication to get the current vaccines or any vaccine that is not live. The next vaccines coming down the road are probably J&J and AstraZeneca, and then probably Novavax and other protein-based vaccines, where basically you're injecting a spike, like a protein that's like the spike protein. None of those are live. There are only a few attenuated vaccines, and they originate in China, maybe Russia, where they're actually injecting a live attenuated weakened virus. That obviously will probably never make it to these shores because we have enough of the other vaccines. But if they somehow, the patient travels or they're going to some part of the world and that's what they're offered, if they are on any immunosuppressive drug, it has nothing to do with IBD, they can't get a live attenuated vaccine. Not a concern for us here. Now, where is the patient going to fall with IBD and their medications? Again, take-home message, give them the vaccine when they're eligible. None of the immunosuppressive drugs are a contraindication. Now, where is this going to, where are the IBD patients going to fit? And I speak to Hani all the time, and I don't know if you guys realize what a treasure she is and how important she is to New York State. And I'm not sure if it's a secret, but let's put it this way. She knows a great deal about who is in what phase and what phase we're in. So a quick review. because this is very impactful, and I apologize if this is very common knowledge. 1A, as you know, most of those people have already been vaccinated. Those are chronic care facility residents and healthcare workers. That was 1A. And now we're already in New York in 1B. Now, what are these? CDC, the Center for Disease Control, which is not the FDA. FDA approves drugs. CDC is the organization, obviously, you know, is involved in infection control, epidemics, and I've spent an enormous amount of time for a month, enormous amount of time. These are not casual recommendations. They have 29 committee meetings of some of the world's expert vaccinologists, infectious disease, epidemiologists sit in a room, and they came up with this. 1B, 1A, 1B, 1C, and 2. 1A, we've basically moving into 1B. What's in 1B? 1B is anyone over the age of 75, and from what I remember, there's not that many people in the Refuah capture area, at least in New Square, over the age of 75, but over the age of 75 can get it now. 75, not 65. Who else? Essential workers, let's call them first tier essential workers, which include teachers, and I might leave some out, but teachers, firemen, EMT, police, transit workers, people who are front facing in groceries who are exposed all the time, people in meatpacking plants. Those are essential workers for 1B, which is where we are now. Healthcare workers in doctors' offices. My office was contacted on Friday that everyone in your office who is front-facing with patients can come in. They are in the group of essential workers in that sense. That's 1B. 1C, and this is where this is relevant to our IBD patients, is going to be based upon anyone over the age of 65 without a disease, anyone over the age of 65, or over the age of 18 to 65, because 65, you get it either way, 18 to 65 with a chronic disease that increases your likelihood of a bad outcome. Strictly speaking, and I have not gone down, drilled deep down enough to actually find some place where they consider Crohn's and colitis a chronic disease that increases the risk of bad outcomes. And in fact, it does not. Having said that, it's not the Crohn's or colitis that might get you into 1C. And obviously everybody wants to get into the highest phase to get it sooner. If you are on any medications, according to CDC, this is the latest guideline, December 23rd, and as of 2 nights ago, it hadn't changed yet. Anybody on a quote, medication that is immune weakening, and obviously they name steroids by name, but any of our immunosuppressive drugs or chemotherapeutic drugs, even if you're on a perfect remission for years, gets you into 1C. And they don't really know our secure COVID registry that actually Stelara and Entyvio and anti-TNFs don't really increase your risk of bad outcomes. It might even prevent them. On the other hand, that's in there as, quote, immune weakening. So your patients with IBD, even if they're 18, they don't need to have one of the bad chronic diseases to be considered 1C. What are the bad ones? Ones we're all familiar with: lung, heart disease, diabetes, hypertension, obesity, a very important one we might overlook. So the obesity patients, the obese patients can get into 1C. And others that I'm sure I'm leaving out: transplant patients, patients with cancer, and chemotherapy being, quote, an immune weakening agent. So that's what you have in 1C. So this is what I'm telling my patients. You're not in 1B now, because you're not 75 or over, and you're not an essential worker, unless you are. The other people in 1C, and this could swing people into 1C. Let me make a point. 1C, you say, gee, it's already the third phase. What's the use? Because after 1C is when the other 330 million people living in the United States, phase 2, can come and get their vaccine. So that's when you got the really long lines, okay? So 1C truly is something to aim for. So besides what I mentioned, over the age of 65, chronic diseases or immune weakening diseases, immune weakening medicines over the age of 18 is the second tier of essential workers. And a lot more people fall into there. And you'd be surprised to know that these are people that are considered important, vital for the infrastructure of our country, including people who are lawyers. Apparently we need lawyers for this country to run well. People in the financial industry, people in media, So if you see some celebrity getting their vaccine, it's not that they're necessarily cutting the line. They've been considered essential workers, people in IT, people in construction. So there are going to be a lot of people. Now, remember, the CDC guidelines are just that, they're guidelines. Each state can make their own recommendations, and it's going to be a moving target based in part on how many doses you have available. What is the epidemiology of your patient population? You maybe not have too many 65-year-olds, but you have many, many 25-year-olds who have other diseases. So how you move between the phases is going to be determined by a lot of factors, and probably a lot of jockeying, frankly, by lobbying and unions, etc. But 1B is where we are now. 1C is where I personally, thinking about my patients, I'm thinking that I'll be able to get it for them. No drug is a contraindication to these non-live COVID vaccines, and patients are pretty savvy, and we know that with our biologic drugs, we like to follow their drug levels. We want to find them in a therapeutic drug level. And the higher that drug level, you see, the more they are immunosuppressed. Now remember, it's not a contraindication to get the vaccine. The question becomes, if you are on an effective immunosuppressant, will it block your ability to make the appropriate antibody response to the vaccine? And we know this, for instance, from hepatitis B. Most people with hepatitis B vaccination, they're immune after the second or so of the 3-dose vaccines. Many IBD patients on our immunosuppressants need even more than 3 vaccines. So there is reason to think that maybe our patients on immunosuppressants, they'll be, quote, promoted into 1C, but they might not get the adequate protection we're hoping they get. We just don't know. Then people say, gee, should I wait a few weeks away from when I just got my Stelara or my Remicade or Humira? The IO-IBD, again, this is the gurus of the IBD world, are saying, no, don't wait. When you could get it, get it. Don't think about, do you have too much Remicade in your system that you won't make an antibody response? Ultimately, we might say, maybe wait a few weeks. If you're on prednisone, we certainly want to try and taper you as quickly as possible. But right now, our official recommendation is no medication is a contraindication, and get it when you can. So take-home messages, and I hope, Connie, I didn't go over too long, which I probably did. IBD and COVID and the COVID vaccine, take-home messages. IBD patients are not at greater risk for COVID infection unless on steroids, and on the other hand, they're now at lesser risk. So for all those people walking around still not observing the appropriate precautions, they still need to get their lectures. IBD patients are not at greater risk of a severe outcome. So if they do get infected, God forbid, and they are on our medications, you could tell them that it's not a problem. Maybe the anti-TNF in particular reduce the likelihood of a bad outcome, except if they're on steroids. One other reason that in the world of IBD, we want to get all our patients off steroids. Increased risk of severe outcome if on steroids or 6-MP. Patients with IBD immunosuppressants are promoted, so to speak, for 1C, and when you can, get the vaccine as soon as possible. So that's my talk, and I'll be happy if anyone's still listening, to answer any questions you may have.
I don't see any questions in the chat. Alex, if you have anybody that's wanting to ask a question, if you can jump in. Other than that, Dr. Crohn, if anyone has questions after the webinar, I'll ask them to send me an email and I'll forward it to you.
Okay, my pleasure. I want to thank everybody and dialing in. I think Connie's been unbelievably ahead of this and trying to encourage everyone to vaccinate our patients. And she taught me something, and I give a lot of these lectures to GI guys in general, and that is, and I've learned this from Connie, I believe it, the greatest motivator to get our patients to take the vaccine, and there's legitimate vaccine hesitancy. I'm not talking about the anti-vaxxers or the conspiracy theorists. Is vaccine hesitancy is legitimate. This is a brand new vaccine. There's never been a vaccine that has come to market within 9 months. And it is a new technology. RNA is new. As Connie told me, the doctor is the best ambassador. The doctor, the nurse, the PA, the person who's sitting with the patient in the room. And hopefully after this, you will have enough information to have a little more confidence to convince your patients about the importance of the vaccine if they have IBD, and even if they're on one of our immunosuppressant meds. So I thank everyone. I know you must be exhausted. I talked for too long, and it's Monday night. So thanks, everyone. And Khani, if anyone's interested in the slides, I'm happy to share them with you after the talk. I'm more than happy to.
Thank you very much, Dr. Cornbluth. And thank you to all of you who joined. And let's all stay safe and healthy. And we'll be seeing each other in better times, hopefully soon. Thanks again. Bye-bye now. Good night.
Good night.